Thanks, PK, and for all the organizers for the kind invitation. My charge today is to really look at what we've just been chatting about, which is every one of these trials, as Bill was describing, is so heterogeneous that you cannot crosstalk any of these device trials. So that where they all fail is Restenosis, and hopefully we can come up with a nomenclature that may be useful to this. These are all my financial conflicts, serving as PI for some of the trials in here, but nothing germane specifically to this talk. So in general, the challenge of femoropopliteal disease is, we have a fair number of folks who are with PAD, at least in the United States and worldwide. No single device. Everybody who comes up here to chat with you about different devices, there's no one gold standard today because we don't have those head-to-head comparator trials, but they're slowly coming down the pike, and I think that's going to be useful. Multiple factors influence operator selection as to what they choose for devices, and all devices have a primary patency, but they also have a primary restenosis rate, which is critical. And therefore, really trying to characterize this failure mode is the real basis of why this came about. So the motivation, we have the Moran criteria for the coronaries. We have the Tosaka classification for in-stent stenosis in the SFA. But as has been shown, there are a lot of different alternatives beyond just stenting. We have DCB now. We also have atherectomy followed by DCB. And so you have a lot of different opportunities that aren't specific to a stent. So we really wanted to develop a scoring system that would be agnostic, really just completely separate from the outcomes based on the index procedure, and just look at those outcomes alone as to a restenosis pattern. So we brought together a team, some of which are on panel here today, including cardiologists, interventional radiologists, vascular surgeons, angiologists. Industry, this is a Medtronic sponsored, at least they allowed us unfettered access to their trials. And Mark Turco and Chris Tichet with the rest of the group really deserve a huge amount of support, and thanks for allowing us to do this moving forward. And we use core lab adjudication back to Synvicor, despite 2 core labs being used initially. And so if you look at the overall group of patients that we looked at, about 2,300, almost 2,400 patients enrolled in randomized or registry trials through the Medtronic system. And then we looked at every one of those restenotic patients at 486 folks at the 12-month endpoint. So anybody who came in that first 12 months is the group that we were going to be looking at. We had to define a couple things. We had to define what's called the intended or index-treated length. And with a stent trial, it's very easy because there's a stent there, so you know exactly where the lesion initiated. For the non-stent group, what we had to do is go back to the lesion as in the index procedure and define that level so that we can go back at the follow-up and look at the lesion specifically. So what we came up with was a scoring system that's 5 points. First would be focal, less than 20% of the intended treatment length, either the proximal edges or within the stent itself, and this is an example of that. Or we go with multifocal lesions, multi-level disease requiring that is less than 50% of the ITL, but with 3 centimeters or greater separation between the lesions, and this would be an example of a multifocal lesion. Or we went with moderate lesions, which are around 50% or less, but regardless of separation, had to be generally less than 3 centimeters, things that encroached upon each other, and this would be an example of that. And then you had the diffuse lesions, like was shown previously, with greater than 50% of the intended treatment length, regardless of separation. And ultimately, as Andre was just showing you, occluded artery is fairly easy to score as being occluded. So these are the 5 points that we're going to be using and stake our, put our stake in the ground as to whether or not this is a defined endpoint. The limitations for this outcome are that only a Medtronic series of devices have been used. So atherectomy, directional atherectomy was used. DCBs were only the Impact Admiral, both in the randomized trial as well as in the registry. No peripheral stent grafts are evaluated here. No peripheral drug-eluting stents have been evaluated in this evaluation. And only complete and high-quality images, both at index and at follow-up, are evaluable. Lesions outside of the intended treatment length, remote lesions that have progressed, creating the TVR, were not evaluated in this diagnostic criteria. And procedural and technical classifications are really limited to those patients who presented after 30 days. We took out the acute 30-day outcomes of acute thrombosis or occlusion. We didn't think that that was germane to this discussion, but we also wanted to take away acute procedural complications from this analytical plan. So if you think about the process, what we have now is not only a defined endpoint of restenosis, and now we can actually look and crosstalk every one of these outcomes back to the index procedure, back to the demographics, the association with calcium, time to TLR, some ideas on baseline stenosis, and the eventual key will be treatment modality, which I think will be a remarkable piece of information. So this is the way we've applied it, at least initially. These are not the final processes, but I just want to show you what we can see when we look at the application of this defined process. So of 202 TLRs, remember that there was over almost 500 total cases that were going to be evaluated. 145 were unevaluable due to poor angiography. 63 were disqualified as not having a greater than 50% stenosis. Focal lesions tended to return as focal lesions. So the baseline at the bottom here is grades 1 through 5, and then how they return is in the top, separated by the bar graphs. Whereas diffuse and occlusive diseases, as you would expect, return. So this end-stent restenosis that returns, it begets restenosis, comes back chronically and more consistently as diffuse. Of the primary and preliminary analysis, when you look at treatment modality of the lesions that were tested, 7 were unevaluable and 65 were disqualified for being less than 50%. Lesions treated with PTA came back or failed more often in a focal way. Understand that this is across all treatment options in all these trials. Most of these were very short lesions. The interesting thing was that in the DCB group, we had and you have to understand the context here, of the 7 failures in the randomized trial, so it's a very small number, many of these patients returned with a failure that was more diffuse than focal. But some important issues really need to be understood by this, and that is that lesions treated with PTA really were entered into the trials evenly distributed from focal to diffuse to even occlusive disease. Whereas lesions treated with DCB tended to consist more, at least at these groups at baseline, with occlusions, potentially confounding this outcome. Again, remember the numbers are much more truncated at 7. The point of this was the applicability of this scoring system to show that it does have some value in being consistent. We didn't have a lot of dropouts with, like, one of the definitions not being used very often. Every one of them had a defined endpoint that actually took patients into those endpoints and actually was adjudicatable by a core lab as well as by the panel of reviewers. We also looked at calcium. I know Chris Rocha-Singh is very interested in this aspect, and he will be going further into this as this evaluation continues. Of the 241 lesions, 47 were disqualified as either below-knee lesions or restenosis less than 50%. But there did not seem to be a clear trend, at least from the initial foray of 194 TLRs, between calcium severity and restenosis morphology, which was a surprising finding. But device-specific analysis regarding the effect of calcium may add some clarity to this. You may separate out atherectomy devices versus stenting, but that does become an important conundrum as we move forward. So in summary, the existing restenosis scoring system really lacks descriptive value for non-stent treatments, particularly DCBs and atherectomy, and complex femoral popliteal artery lesions. The proposed system that we have come up with really provides an all-inclusive nomenclature with more description of the failure morphologies that I think will be critical. These may provide more information regarding subsequent therapy or therapies as you move forward in treating patients with claudication or critical limb ischemia. The potential determinant for index procedural technology may also play a role. If you know that a device which costs whatever can fail at whatever process of failure modes, if that happens more often with that device, you may choose a different device. The pattern of restenosis may actually unify most of these device trials such that you can actually have, beyond head-to-head comparators, you can actually say your primary patency is X, but you also have a failure mode, which is Y, which may actually be a very critical part of the information. And the initial review suggests that there are some differences between modalities in the patterns of restenosis, and really, ultimately, our further analysis will become important in defining what I believe is critical in this country and worldwide right now, which is health economics. Thank you.